Assalamualaikum. Now the history nephrotic syndrome. The scenario may be 3 to 4 years old child presented with generalized swelling and reduced urine output for last 7 days. Take focus history and write down and discuss the management plan. So as usual, the history format. Hello, good morning. This is Dr. Ruxana, one of child doctor here. I am speaking to Salma, mom of Alif. Thank you for coming. From GP note, I came to know that you have concern regarding Arif Hill's condition. So is it appropriate time? I'm here to take the focus history, and during this discussion, if needed any important note, I have to take. So is it okay? Okay. So will you please tell me what is your main concern? So mom may tell the story of that she developed the swelling. So when you notice this, does this progress over the period of time or remain the same? At the which part of the body it is started and how it is spread, and is it itching present or not, does it painful or not, and anything any part of the time of the day does it change, and any factor that make it relapse or any factor make the condition more worse. So this is the history of the swelling, and then immediately we will ask about that. Do you have any concern regarding her P? What is the amount? Is it how frequently she pass it? Do you notice the color of his P? Does she complain any kind of pain or burning sensation during the maturation? And then we will ask, does she has any recent history of bee sting? Okay. And then the history of the constitutional symptoms. Does she has any kind of fever? Do you have any concern regarding his weight? And what's about his activity? And do you have any concern regarding his sleeping? And then the systemic review. So systemic review from the CNS. Does she have any kind of fits, any loss of consciousness? Does she any complaints of any kind of headache, any weakness, any part of the body? And then does she complain any raising heartbeat? Do you measure his blood pressure? And any cough, any breathing difficulty, any kind of tummy pain, any throw up? What about his poo? And any joint pain, any skin rash? And then ask, and do you think that she has any unusual face? Do you have any concern regarding his hearing and vision? And now the past pregnancy history. Do you have any concern when Arif in your tummy? During the before the and during the any concern regarding the birth period and after the delivery? And we will ask it very slowly, one question by another, and we should take care that at a time we shouldn't ask two questions. Okay. And then past illness. So the past illness, does Arif has any long standing illness other than this? Did she miss any kind of hospitalization before? How many? If yes, so how many days, and for which condition? And now what is the update of this condition? If no, so does she take any kind of medication regularly? And she is suffering from this swelling and decreased urination for last 7 days. So what did you do for it? And does she has any kind of did he undergo any kind of surgery, any kind of trauma? And then the history of will you please tell me about his diet, and do you have any concern regarding his development? And then ask about, does she have any kind of allergy to any food, any medication? And then did she receive all of his jabs, any extra jabs? Is very important in case of nephrotic syndrome, especially varicella vaccine and pneumococcal vaccine. And then family history is also important here. Would you please describe your family for me, and is your partner and you blood related, and is the similar condition in the family, because it may be Alport. Okay. And then congenital nephrotic syndrome has autosomal recessive pattern. For this reason family history is important. And then any chronic illness running in the family that you would like to mention. Okay. And then the financial history, what do you do for your living, is it satisfactory, do you need any kind of extra help. And then ask about the schooling, any kind of bullying, what's about school performance, and home environment, and what's about the impact of this disease on your life and on Arif's life, and what is your biggest worry. And thank you for discussing sharing all the information of Arif with me. Okay. And then we'll present the case that today I meet with Salma, Arif's mom. Arif is 3 years, presented with generalized swelling and decreased urine output for last 7 days, and there is background history. He has some tummy pain, and the swelling start around the puff. There was puffiness of the face, then it becomes the generalized, but there is except decreased urination, there is no urinary complaint, no joint pain, no family history of such illness, and parents is very much worried. Could it be the kidney problem or not? So how will you examine? For examination, airway, breathing, circulation, vital sign, especially the blood pressure, and edema, examination for the edema, does it pitting or not, and hydration status, parabdominal examination, is tender, palpable kidney present or not, and anthropometry, chest for proliferation, heart, CVS for the pericardial effusion, and neurology if there is any history suggestive of it. And so what could be the differential diagnosis? If it is the initial presentation of nephrotic syndrome, so the differential diagnosis can be, it could be nephritis. However, as the age is 3 years, it doesn't supports in the favor, and the color of the urine is not supportive of it. And then what could be the allergy, it could be following the cardiac disease. This generalized swelling is but there is no history of palpitation or breathing difficulty. It may be the liver disease, but there is no history of the jaundice. It can be anaphylaxis, but there is no history of exposure, and it can be CKD, as there is swelling and decreased urination, but there is no history of prolonged long extending illness. It can be hereditary angioedema, but as there is urinary complaint is present, so we can exclude it. It may be protein losing enteropathy or malnutrition, but feeding history was normal, and they have no concern regarding the bowel habit. But if it is suppose a relapse case of nephrotic syndrome, so what could be the differential diagnosis? Nephrotic syndrome relapse can be following by any infection, poor compliance, or is other than the minimal change disease. And it can be multi-system disorder, this which includes the SLE, henosis purpura. If it is the initial presentation of nephrotic syndrome, we can consider this at the last, and if it is the relapse case, we also consider multi-system disease here. And then after the differential diagnosis, how will you manage the case? So first of all, the investigation for nephrotic syndrome. The investigation, urine ELISIS, early morning protein creatinine ratio, and if it is we expect if nephrotic, then more than 200 milligram per millimole, and baseline urea electrolytes, serum creatinine, serum albumin, serum cholesterol, immunoglobulin GAM, complement C3, C4, zoster immune status is very essential, and hepatitis B and C serology, full blood count. And second line investigation, ASO titer, ANA, anti-double strand DNA. And then the management. So if I will go through, if the child is stable, so we will admit the child, stick the fluid intake and output, urinary intake and output, urinary output and fluid intake chart, and we will avoid the added salt, and we will involve our consultant. And the fluid restriction in the manner of 300 ml per meter square as insensible loss plus previous day's urine output. And medication, prednisolone is the drug of choice, and we should continue it 60 milligram per meter square or the maximum 80 milligram per meter square for 6 weeks, followed by 6 weeks single morning dose, followed by 40 milligram per meter square at alternative days for 4 to 6 weeks, and then tapering over 3 to 4 weeks. And furosemide we can consider if there is any discomfort or there is upsetting, this edema is upsetting the patient, and phenoxymethyl penicillin if the edema is present. And here if there is allergy to penicillin, so we can consider azithromycin. If there is no oral form of azithromycin, so we can consider amoxicillin. And yes, and then we have to take the measures for the infection precaution and vaccination follow-up. And in the follow-up we have to maintain about we have to teach the parents how to monitor urinary dipstick for urinary protein at home, and diary for urinary proteinuria, and also diary maintenance for the corticosteroid. And then what could be the complications of nephrotic syndrome? Hypovolemia, and then infection such as the peritonitis, cellulitis, and renal vein thrombosis. The features of renal vein thrombosis are abdominal pain, high color urine, and palpable kidney. And management investigation for renal vein thrombosis is Doppler, color Doppler ultrasonography or with Doppler study to look at the perfusion and to image the renal vein and inferior vena cava. And also in case of renal vein thrombosis, the platelet level will be decreased, there will be increase of D dimer and reduced APTT. And management of peritonitis. Peritonitis is difficult to recognize, there will be abdominal pain, and here we have to exclude also the is it is appendicitis or not. And because if there is abdominal pain and we suppose that it is due to peritonitis, so we will send the blood culture and send the fluid, peritoneal fluid, for gram staining, and until the result come we can continue piperacillin tazobactam. And then management of hypovolemia, how we can consider it, that the child, either the child is in hypovolemic or how we measure the dehydration status in case of nephrotic syndrome. So the pulse will help us, it will be low volume 3D pulse, and blood pressure may be low, and there will be abdominal pain, and there may be cold periphery. And how will manage a case of hypovolemia? So the presentation of hypovolemia, abdominal pain, vomiting, looks unwell, and we will seek the senior advice before the fluid resuscitation. We can administer 10 ml per kg normal saline, 0.9% sodium chloride, and start dipyridamole. And then if there is low JVP, rising urea electrolytes, and non-responsive to furosemide, so we can after consultation we can start 20% albumin. And then causes of abdominal pain in case of nephrotic syndrome, it may due to steroid, renal vein thrombosis, peritonitis, hypovolemia, UTI, appendicitis. And what is relapse is there is 3 consecutive protein early morning proteinuria in having previously in relapse or in remission. And the management of relapse will be prednisolone 60 milligram per meter square until remission, and then 40 milligram per meter square every alternative day at the single morning dose for 4 to 6 weeks and taper over 3 to 4 weeks. And then the infection precaution during the vaccination. We have to avoid all kinds of live vaccine 3 months for 3 months after completion of the high dose oral prednisolone. And this is about the for the live vaccine, but for the inactivated vaccine we can consider the same protocol, but if it is not possible to continue this protocol, so we can give the inactivated vaccine after a shorter delay and we have to check the antibody response. And now the question that the history of exposure with varicella or zoster in a case of nephrotic syndrome, how will you treat this? So if there is exposure to chickenpox or zoster and the child is non-immune, how can we say that non-immune? Because at the very beginning of the investigation we send the varicella zoster immune status. Suppose it is varicella zoster IgG is negative and patient has a strong exposure less than 2 weeks of the onset of the rash and until all the rash are crusted. This is the infection period. And suppose our nephrotic syndrome child is come contact with this exposure and the child is non-immune, so we have to administer IM varicella immunoglobulin. Yes, and then but if there is the symptoms of varicella, we have to give IV acyclovir. And we have to vaccinate this child by varicella vaccine between the relapses. And we have to also advise for pneumococcal vaccine, pneumococcal conjugate vaccine. And now the indication to refer for the pediatric nephrologist. If this is corticosteroid resistance case, a frequent relapse, corticosteroid dependent case, and a significant corticosteroid toxicity for regarding corticosteroid, and if they onset less than 1 year, more than 12 year, if there is symptoms suggestive of nephrotic syndrome, macroscopic hematuria, high blood pressure and renal insufficiency, low C3 or C4 and a positive. Here in this all cases we have to refer for pediatric nephrologist. And what is the steroid resistance? After initiation of 4 weeks of high dose steroid, if there is no remission, so we can consider it as a case of corticosteroid resistant nephrotic syndrome. And what is corticosteroid dependent case? If there is relapse within the treatment of alternate days corticosteroid or within 40 days after the remission, we can consider it as corticosteroid dependent cases. And what are the immunosuppressive drug we can use for nephrotic syndrome? This is cyclophosphamide, cyclosporine, tacrolimus, mycophenolate. And the complication of cyclophosphamide is hemorrhagic cystitis, hair thinning, bone marrow suppression. Complication may arise from the cyclosporines are we can remember in this way that cyclophosphamide for hair thinning and cyclosporine for excessive hair, that means the hirsutism. Another important complication of cyclosporine is gum hypertrophy, and also cyclosporine is nephrotoxic drug. Tacrolimus also immunosuppressive agent, causes nephrotoxicity. Mycophenolate, the only complication of this medication is it causes the GIT intolerance, but there is no nephrotoxicity here. It is all about the nephrotic syndrome. Thank you.